You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 21st, 2024, Summer Solstice. This week, we'll do some listener feedback, coronary autoregulation, the hubris of U.S. doctors, non-STEMI and older patients, survival after STEMI, and new leaders at JACC. Some quick feedback. Last week, I received a bunch of emails about quote attribution. The quote was, "Prediction is difficult, especially about the future." I said it was Yogi Berra, but many said Niels Bohr said it many years before Yogi. Okay, I looked it up. I think they both said it. Another comment, though, from Dr. Doran Zager, centered on my coverage of the combined analysis of RALS and emphasis trials. This was the first author Matsumoto paper in JACC. This paper looked at the effect of MRAs, mineralocorticoid receptor antagonist, in a subgroup of patients who had a drop in GFR to less than 30 milliliters per minute per 1.73 meters squared. The authors found that these patients had a higher risk of the primary outcome compared with those who did not have a drop in GFR, but the effect of MRA persisted. Dr. Zager smartly points out that of the 295 patients in both arms, the MRA and placebo groups, who had a decrease in GFR, 1 in 4, or 78 of these patients, discontinued the MRA therapy. And so he wrote that these discontinuations were probably mostly decided by the study team based on judgment and hyperkalemia. And we are not told whether such discontinuations were protocol mandated. Therefore, Dr. Z argues a more accurate interpretation of the results would be that the benefit of MRAs is maintained among patients who experience a GFR decline, provided their physicians did not decide to stop the medication. So he felt that a take-home message that MRAs may be continued in the face of GFR decline would be both inaccurate based on the data and potentially harmful. Now, I really appreciate this point because it emphasizes trial environments versus real-world care. But I should have mentioned when I covered the study, though, that the authors thought of this issue and they did a sensitivity analysis depending on MRA discontinuation or not. And the hazard ratio remained beneficial even in the small number of patients who discontinued the drug during the trial. However, the numbers are small. It's in the supplement, and I reiterate my comment that I made last week, and that was we always need to be mindful that individuals are not populations, and that these net benefits were obtained in a trial setting where you can be sure that there was careful monitoring of things like potassium and blood pressure. All right, next topic is coronary artery autoregulation with increasing stenosis. We're going to talk coronary autoregulation. And now I know that's a bit of medical jargon, but at the core of this issue is the matter of why people do so well with severe coronary disease. Now, angiograms often don't match up with symptoms. Angiograms are often much worse than symptoms. The New England Journal of Medicine published this research letter of sorts. It was on a single patient, 63-year-old patient. He had refractory angina. He had had an LAD stent. Now imagine a study in New England Journal of Medicine with one patient. You know it's going to be an elegant study, and indeed it was. This patient then had a pressure and wire placed in the distal LAD after the stent was placed. And get this, the investigators then placed an undersized balloon within the stent that they just did, and they tested at varying degrees of occlusion. They then plotted the distal LAD pressure and absolute coronary flow. Now, they can plot flow because they have a temperature sensor. It's like thermal dilution. This is sort of similar to an FFR. And they did this exercise at rest and then with a saline infusion to simulate hyperemia. What they found is that resting flow in a distal LAD remained stable over a range of distal coronary to aorta pressure ratios. Let me say that again. As they inflated the balloon and caused varying degrees of epicardial stenosis, distal flow did not change. Why? Because the coronary microcirculation vasodilates and compensates. Increasing epicardial resistance induces this instantaneous microcirculatory vasodilatation that results in a compensatory decrease in microvascular resistance. Now then they did hyperemia. First point, the flow increased by 4x. But then, as the balloon was inflated, creating more and more stenosis or gradient, flow decreased in a linear fashion. Hyperemic flow approximated this linear relationship with the FFR reserve, and it decreased from 176 to 81 milliliters per minute. Taken together, these two findings show the autoregulatory capacity of the coronary microcirculation. Maybe you two don't think about the microcirculation that much, because modern cardiology seems to focus on the epicardial stenoses. We can stent those. We can see those. The total coronary resistance, therefore, is the sum of epicardial resistance, the stenosis on the angiogram, plus the microvascular resistance. And I was struck by the fact that flow was absolutely maintained despite major stenoses because of the instantaneous vasodilatation of the microcirculation. The three Belgian authors also showed that the vasodilatation in the microcirculation can max out, and then with increased demand, flow goes down. Earlier in the week, I spoke with Dr. Venk Murthy from the University of Michigan about this study, and he emphasized that people with microvascular dysfunction, say from diabetes or obesity, hypertension, other conditions, may lose the dilatory properties of the microcirculation, and if that happens, 30%, 40% stenoses may cause significant ischemia. This is a super elegant study. I'd take a look at it and keep thinking about the microcirculation. It's not just about those epicardial stenosis that we cosmetically improve with PCI. I mean, maybe one of the great reasons why medical therapy is so beneficial is not just treating the epicardial stenosis, but in modifying the microvasculature. All right, next topic is about the Recovery 4 Impella trial being halted. The Recovery 4 trial was an RCT of the microaxial flow pump versus standard care in infarct-related cardiogenic shock. Now, normally you all know I have an allergy to using brand names, but here I make an exception and call the microaxial flow pump Impella. Recover 4 had started 8 months ago. Abiomed, the makers of the flow pump, funded the mostly U.S. trial, and it was similar to the Danger Shock trial, but the primary outcome of death in Recover 4 was to be measured at 30 days, not 180 days like it was in Danger Shock. This week, however, trial authors announced that the trial was halted because of the positive results of Danger Shock, and I learned of this on Twitter or X. The Data Safety Monitoring Board felt that there was no longer equipoise. Dr. Greg Stone wrote on Twitter that they had spent 2 years designing Recover 4 and were motivated to continue, but imagine approaching a shock patient or family saying, quote, one study showed the device might offer a 1 in 8 chance of saving your life, but there is some uncertainty, so do you agree to a 50% chance of not getting this device? Now, I respect Dr. Stone, but I could not disagree more with this sentiment. Again, I'm not dissing on Dr. Stone, I'm dissing on this idea. I've covered Danger Shock, and I've written that I believe the positive results are indeed likely reflective of the device. But there are many buts. But this is not the same thing as saying doors closed and Impella is 100% beneficial. My argument against Dr. Stone's point of view is that Danger Shock is not bulletproof. And let me tell you 8 reasons why we should think that. First, This was a trial that took a decade to enroll 360 patients. They screened 1,200 in danger shock, excluded 850 patients, and enrolled only 360. I'm also told that the primary investigator, Dr. Jacob Moeller, was a force of nature, making sure that the trial enrolled patients who met the strict entry criteria. Again, this was a highly selected group. Even so, the standard arm of danger shock had a near 60% death rate, which is higher than some previous cardiogenic shock trials. There was an imbalance in ECMO use in danger shock. The p-value of danger shock was 0.04. The fragility index was only 4 events. Now, Dr. Stone, in his comment, refers to a 1 in 8 chance the Impella reduced death. That comes from an absolute risk reduction of 12%. But again, with this few patients and a p-value of 0.04, it could all be noise. Also, I think really important is that at 30 days, there was clear overlapping of the Kaplan-Meier curves. RECOVER-4 was going to measure its endpoint at 30 days. And finally, explain this to me. I don't understand this. In the as-treated analysis of danger shock, the risk reduction did not meet statistical significance. So if the Impella effect was bulletproof, you'd expect the as-treated analysis to be more robust, not less, than the intention-to-treat analysis. Seriously, friends, I am so frustrated with this decision and the entire device acceptance situation in cardiology. I find it sad. One of the draws for me going into cardiology was its leadership in generating evidence and its bravery. I started cardiology in 1991, the year that CAST was published. That was a brave trial. In my view, key opinion leaders like Dr. Stone and the PIs and the DSMBs are academics. They know these 8 reasons why danger shock is not bulletproof. We depend on academics to be leaders in not only generating the evidence base, but also shaping opinion. And the opinion they should be shaping in the case of LV support devices in cardiogenic shock is one of equipoise and uncertainty. Halting this trial just reinforces the United States doctors' view that Impella is clearly beneficial, and therefore patients can't be randomized. Of course, since compensation is so strong for Impella devices, there's a bit of Upton-Sinclair effect that influences the lack of equipoise belief. Recall that Upton-Sinclair famously wrote that it is difficult to get a man to understand something when his salary depends on him not understanding it. Dr. Sanjay Kaul wrote on Twitter that SGLT2 inhibitors did not stop after the first one was positive. I am not sure that danger shock replicates outside of Denmark. In the supplement, patients recruited in Germany, for instance, in danger shock did not have a benefit. It was all from the Danish centers. That speaks to the carefulness of PI Jacob Moeller. But Jacob Moeller cannot govern all Impella implants. If you believe in Impella, you should want a second trial to confirm your belief. The trial could have an adaptive design. There could be early looks to rule out any clear benefits and stop the trial. Finally, a final comment on the matter of device approvals. Impella got approval years ago without RCTs. Left atrial appendage occlusion devices got approval despite the last regulatory trial Prevail not meeting non-inferiority in its co-primary endpoint. Tricuspid devices are now approved recently based on quality of life data, and the trials were not placebo-controlled. These are embarrassing things. Think about danger shock. If this were non-significant, we'd have implanted a non-beneficial device in many thousands of patients over a decade. Regulation of devices, I think, needs a complete overhaul. Now, Dr. Bobby Ye, when I was in Boston a couple weeks ago, explained to me that there are negatives to requiring evidence before device approval because this penalizes first-generation devices. But we should clearly have some evidence before approval, and then we should have an ironclad promise to generate data post-market, not 10 years later, but soon after. And if no data is generated, the device can be removed from the market. Now, doctors can help in my quest to prove devices work before usage. How? By wearing your science hat and demanding better evidence, by being less confident in benefits. The RECOVER decision makes me as sad as I have been in a long time regarding my profession. Next topic is non-STEMI in the elderly. I don't know about your place, but at mine, we take care of a lot of patients who are older than 70 or older than 80. Most of the large clinical trials that guide non-STEMI care enrolled younger patients, like all cardiology trials do. There have been trials of older patients with non-STEMI, but individually these are small and often underpowered. And we know that older patients are different. While yes, they have a higher risk of the primary outcome, MACE for instance, they also have higher risks of treatment-related harm, as well as higher rates of competing risks such as cancer, falls, infection, etc. In younger patients who have high risk, the current guidelines suggest that early invasive approach is preferred over a conservative approach of medical therapy, then angiography and revascularization based on symptoms or risk stratifying test. The European Heart Journal has published an individual patient meta-analysis of 6 trials of early invasive versus conservative strategies in older patients. The first author here is Christoph Kotanidis. Their primary endpoint in this meta-analysis was a composite of death or MI at 1 year. Nearly 1,500 older patients were included in these 6 studies. The mean age, 84 years, 2/3 were KILLIP Class 1, and about 80% of patients had either KILLIP Class 1 or 2 MIs. A primary outcome event, that is death or MI, occurred in 24.5% in the invasive arm versus 28.9% in the conservative arm. The summary hazard ratio was 0.87, but the confidence intervals went from 0.63 to 1.23, so clearly not significantly different. They used a random effects analysis. However, one curious thing, which I don't totally understand yet, is that in the supplement, the summary hazard ratio using a fixed effect model found a similar hazard ratio of 0.82, but much tighter confidence intervals, and the upper bound now is 1.00, so quite close to being significant. They also found no differences in CV death or stroke. The individual components of non-fatal MI and repeat revascularization were lower in the invasive arm. The authors also looked at subgroups based on things like age, sex, diabetes, previous PCI, and found no clinically relevant heterogeneity. One exception might have been positive versus negative troponin presentations of the non-STEMI. Here, the immediate strategy looked better, but there were so few negative troponin cases, I don't think you can say much about any heterogeneity in this effect. The authors concluded that there was no evidence was found that routine invasive treatment for non-ST elevation acute coronary syndrome in older patients reduced the risk of composite all-cause mortality and MI within 1 year compared with the conservative management. However, they write, there is convincing evidence that invasive treatment significantly lowers the risk of repeat MI or urgent revascularization, and they say that further evidence is needed from ongoing larger clinical trials, and indeed there is an ongoing larger clinical trial called Senior Rita from the British Heart Foundation. Okay, my comments. This looks to be a strong meta-analysis. One observation is that they used a random effects model in comparing the trial results. However, using a fixed effect, the results of the primary endpoint were close to statistical significance. They write that random effect models are often considered preferable to fixed effect models as they account for inherent variability and heterogeneity among studies, and they feel that this provides a more realistic and generalizable estimation because it allows for the possibility that true treatment effects may vary across studies due to the diverse patient populations, different methodologies, or other underlying factors. Look, I am a student of statistics, but I have read that there is debate about the application of fixed versus random effects, and I can't say which. I will link to a great discussion on Professor Frank Harrell's discussion board called Data Methods. Either way, though, this combination of 6 studies with individual patient data find no clear advantage of the early invasive strategy. Death, CV death, stroke are no different. Yes, MI is reduced, but the effect is not enough to drive CV death or all-cause death. That makes sense, right? Because recurrent MI has become a pretty poor surrogate marker. And here I should remind listeners of a very important paper from David Brown when he was in St. Louis. In 2021, in JAMA Internal Medicine, first author Kevin O'Fee, they meta-analyzed 144 trials of more than 1 million patients and found that non-fatal MI fails as a surrogate for all-cause or CV death. Now, this is especially true in more recent times because it's nearly impossible to present with any ischemic event and not have a high-sensitivity troponin bump. Now, as for the outcome of urgent revascularization or just revascularization, I find this a ridiculous endpoint in these trials because it will always be higher in the conservative arm, right? The conservative arm of these trials is not medicine only. It is initially medicine, then risk stratification. Many patients with non-STEMI managed conservatively will have revascularization based on recurrent ischemia or risk stratification, and that's part of the conservative strategy. So revascularization is always going to be higher in the conservative arm. So overall, I like this meta-analysis because it highlights the all-important issue of heterogeneous treatment effects. Yes, the seminal trials of invasive versus conservative management do show benefits to invasive in higher risk patients. But these are higher risk younger patients. Older patients are inherently higher risk, but older patients also have higher rates of adverse effects from the treatment and they have more competing risks. As such, in this analysis, there was no obvious benefit from invasive approaches, at least routinely. So, most importantly, if a patient with non-STEMI earns their label as higher risk based on age, we should not apply standard guideline-directed early invasive approaches routinely. This meta-analysis finds no obvious benefit from the early invasive approach, and for me, when that is the case, conservative strategies are generally the preferred one. Okay, next topic. Speaking of MIs not being a great surrogate endpoint, JACC has published an observational study that reveals quite good news and is highly interesting. Researchers in Aarhus, Denmark, first author, and forgive my pronunciation, Pernille Grove Thrain, asked a question about how patients with STEMI who are treated with PCI do over the long term, specifically those patients who survive the early phase. Now, this group used the Denmark registry to find first-time PCI-treated patients who had a STEMI. That's the treatment arm. They then matched these patients by age and sex to 5 individuals from the general population. So this gives them a treatment group of about 19,000 patients who had a first-time STEMI and PCI versus 94,000 from the general population. And here are the results when they compared these two groups. STEMI was associated with a 6% absolute increase in mortality at 30 days. It was like 6% versus 0.2%, and the hazard ratio at 30 days was actually 36x. From 31 to 90 days, though, the excess mortality was higher, but it was only 0.9 versus 0.4%, so here the hazard ratio is only 2.4x. But for 90-day survivors of STEMI, the absolute excess mortality was only 2% higher at 10 years. Here, at 10 years, it was 26.5 versus 24.5%, and the hazard ratio was only 1.04, so only 4% higher. And when you look at the Kaplan-Meier curves after 90 days, they're nearly identical with only a small divergence at about 8 years. So my comments. This is pretty darn amazing. It's a huge testament to modern cardiology. Both PCI and secondary meds are the likely drivers. Second comment, this is a good use of observational data. The authors are not making causal comparisons of two non-random groups. Rather, they are describing outcomes and comparing these outcomes to the general population. Third comment, we've sort of known that PCI-treated STEMI survivors who take their meds do well, or at least we suspected it because it's common to see patients with a distant history of STEMI and PCI. Now we can tell those patients who survive PCI and stent that if they take their meds and they pursue a Aarhus-like lifestyle, they can expect nearly the same lifespan as patients who did not have a PCI. Fourth comment, there is some sobering news from this observation. Scientifically, that is. While we have transformed the condition of MI for most patients, it makes it harder to show gains with any newer therapies. To me, this is exactly why David Brown's meta-analysis paper confirms that MI is now really a quite lousy surrogate endpoint. And composite endpoints of trials are driven by things like urgent revascularization or non-fatal MI are going to be inherently weak. They're weak because this paper shows that surviving a STEMI has essentially no effect on overall survival. That is, if you make it 90 days. So as users of newer therapies, we should expect clinically meaningful gains of newer things, especially if these newer therapies are invasive or costly. Reduction of non-fatal MI is not likely going to be an important endpoint in 2024 or going forward. Final brief comment today, a word to Dr. Harlan Krumholz and the new JACC team. The Journal of the American College of Cardiology sent me an email this week that the first issue under leadership of Dr. Krumholz is coming next week. I met Dr. Krumholz at the old Lown Institute meetings. I recall his spirited lectures about generating better evidence, promoting better critical appraisal, and highlighting high-value care. And it was an honor to meet his team at Yale when I spoke there a few years ago. Now I want to wish the best to the new JACC team. I promise to give you all a fair shake here at This Week in Cardiology. The Journal of the American College of Cardiology is one of the most important adjudicators of cardiology science. I do have one wish. I would love to see a bit of Rita Redberg's JAMA Internal Medicine emerge in the new JACC. Good luck to the new team. It's a really big job. So that's it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give it a rating, write us a review, write a comment on the heart.org Medscape Cardiology website. I love learning from these comments. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.